We'll start, right? Good evening, friends. Greetings from Oncocriticalcaresociety. I'm happy to share with you that we'll have our second annual conference on on 10th August in Harvard Cancer Institute. And to start the momentum of the conference, we'll have series of pre-conference webinars. And among the first pre-conference webinar will be on difficult airways. Uh, to talk on this very important topic, we have Dr. Gunther Pori. He is my very close friend. He is, in fact, a founder member of Oncocritical Care Society, and he is also in the editorial board of Oncocritical Care Journal. And he is very interested in also ECMO and other extracorporeal therapies. Uh, and the other people that will join with him is Dr. Neeraj and Dr. Ashini. Dr. Gunther will moderate the session. And from here, I would like to call Gunther to start the session.
Yeah, thank you, Dr. Saurabh, and thank you all the Oncocritical Care team, Dr. Parveen, Dr. Saurabh, and the Oncocritical Care Society of India for giving us this immense opportunity and such a very important topic. I can say it is one of the most difficult area for a intensivist sometimes, and it's a nightmare actually. So today to discuss on that, we have our speakers, Dr. Ashwini and Dr. Neeraj. So the flow of the events I'll be taking care. And again, thanks all of you, and to continue the sessions, and we'll have such more and more academic activity for all the benefit of all the new intensivist and intensive care practitioner. So that is better. And just to have an introduction, so Dr. Ashwini will be starting with the sessions like the anatomical difficult airways and all the guidelines. And Dr. Ashwini is working with us. She is basically the final year DRDNB fellow, and she will be presenting to us these guidelines. And Dr. Neeraj, our junior consultant from Apollo Hospital, Navi Mumbai. So Dr. Neeraj will be speaking on the physiological airway management and what are the anticipated difficulties and what are the different studies, particularly which are very important for the intensive care perspective. So in between, actually, after the first talk is over, we'll have some question and answer sessions and some round of discussions. And I request the delegates to put their queries in the chat box. And also at the end of two sessions, we'll have a round of panel discussion along with all the our eminent panelists, Dr. Saurabh and Dr. Parveen, if possible, if the time permits, of course. So I first request Dr. Ashwini to start the talk, and Ashwini, please start the talk.
Yes. Good evening, everybody. Thank you, Doctor. Thank you, everybody, for this opportunity. So I'm starting my talk. So today's topic of discussion will be the management of the difficult airway. So I'm starting with this case. This patient presented to our hospital last week. So this guy was 54-year-old male patient, was diagnosed with the recurrent carcinoma of the right buccal mucosa. He was in this T3, N0 and M level, and he was receiving this adjuvant chemotherapy, and presently he presented to us for the 7th cycle of immunotherapy. And the plan was for the peg tube insertion, and for that he was shifted to the endoscopy room. And during the procedure, during that peg tube insertion procedure, the patient became desaturated and had cardiac arrest. So code blue was announced in the endoscopy room, and ICU team was present there. And this was the situation of that patient. So already 2 attempts of the laryngoscopy guided intubation was done, and intubation was done with the then after that we have used the video laryngoscopy for intubation. The grade for the intubation was grade 3, and after intubating the patient was shifted to ICU. So what we found the challenges in this airway was the grade of the intubation was CL grade 3. It was difficult to intubate, and the FONA was not possible in this patient, because as you can see this airway was exposed. And the next patient was this was a 44-year-old female patient who was presented to us with the left hemiplegia, motor aphasia, and left homonymous lateral hemianopia, and after 6 weeks of the partial stage excision of the chordoma. So her CT MRI showed the chordoma of 70 into 50 into 54 nasopharyngeal mass at the level of C1 and C2, and meningioma of the size 27 by 27 into 15 extradural frontal lobe mass with the right MCA infarct. So histopathological examination, lymph node biopsy showed the chordoma. And when she presented to us on the day 2, the patient had stridor, and that mass was compressing her airway, and the patient was desaturating. She was tachypneic, and finally we did emergency tracheostomy for this patient. So these are the two scenarios which we have encountered of the difficult airway. So I'll be talking on how to deal with this situation. So difficult intubation are common scenario in intensive care unit as well as in emergency department and pre-hospital setting, with the incidence ranging being from 8% to 13%. So what are the possible causes? So compromised cardiorespiratory physiology, there is always risk of aspiration. Then presence of specific factors related to the environment. An inadequately trained operator under the tracheal intubation in ICU are more likely to be associated with complications compared to in operating. So the challenges during tracheal intubation that we are facing in ICU are because of the isolated factor. Sometimes infrastructure, the lack of space around the patient, poor access to the patient's head end, poor lighting and trained help may not be available. Then the next factor is equipment. Airway devices like fiber optic bronchoscope, supraglottic airways, video laryngoscope may not be readily available in the ICU, and sometimes timing. So emergency intubation may be required at any time during daytime, nighttime. So there is no any fixed time. So when we will encounter this emergency airway situation. So the next is anatomical challenges. So anatomical assessment. It is a difficult or impossible due to lack of time or patient being uncooperative. And then challenging anatomy that we are facing is maxillofacial trauma, cervical spine injury, airway injuries, burns, and the retropharyngeal abscesses, etc. Then there is always a risk of aspiration because patient will be full stomach. Then gastroparesis, which are associated with the critical illness, and patient may not be fasted and requiring emergency intubation. And then sometimes inefficient pre-oxygenation. It is because of the shunt, ventilation perfusion mismatch from the underlying illness, and reduced functional residual capacity. Then there are many physiological challenges. My colleague will talk about it in detail. So what are the physiological challenges that we are facing is the rapid desaturation. So because of the lack of physiological reserve that often lead to rapid hypoxemia. Then sometimes hemodynamic instability due to critical illness or use of the drug that we are using during intubation. Then there are some operator factors like training, limited airway training, and poor airway management skill. Then experience. Sometimes inexperienced junior doctor have to perform this emergency, have to tackle with this emergency situation, and stress, which is stress because of this situation. That is also the one of the contributing factor. Then the predicting difficult intubation in ICU care. So there is one score which is known as Makocha score that has been recently developed to identify patients with potential difficult airway in the ICU. The score not only consider the patient-related anatomical factor, but also the physiological factor and operator experience. So what is the score? We'll see that. So first component is Malampatti score of grade 3 and 5. If it is grade 3 and 4 is there, then the 5 point allotted for that. If a patient is having the obstructive sleep apnea, then the 2 points are allotted for that. If there is a reduced cervical spine motility, then the 1 point is given to that. If mouth opening is less than 3, then 1 point. If the patient is in coma, then 1 point. If saturation is less than 80%, then 1 point. And if operator is non-anesthesiologist, then 1 point.
लवकर आलीस काय जेवलीस का क्लास सोडलाच नाही काय म्हणाल आताच फोन आला होता का तुम्हाला
So I request you to
मग
please
मी फोन केला होता
mic on silent.
करवायचा
दर्शन
हो का तिथं करायचं आहे का
Lot of
Huh?
disturbances are going on. Please
काय
keep
कसं
your
करायचं?
mic in the.
नसा एकट्याचं घर आहे तर तिने फोन केला
Yes, Dr. Ashwini, you can start.
So how to interpret this score? This score has maximum 12 points. If the 0 point is there, then it is a easy intubation, and 12 point predicting the very difficult one. Then other physiological factor that need to be considered, that is subsequent hypotension, hypoxemia, lack of pre-oxygenation, obesity, and age more than 75 years are the relevant risk factors for cardiac arrest. Sometimes there is a right ventricular dysfunction is also an increasing appreciated risk factor, as perturbation in gas exchanges there, acid-base status, and intrathoracic pressure that lead to cardiovascular collapse. Then special consideration during tracheal intubation in ICU. So the presence of two operators should be there, and the one operator should be experienced one. And then we should always call for the help. In addition to two operator, if we are we are encountering with the difficult airway, it is always better to call for the help at the earliest. So it is also recommended to call for additional help when final attempt at rescue mask ventilation fails and when we are proceeding for the emergency cricothyrotomy. Now regarding pre-oxygenation and peri-intubation oxygenation in ICU. So oxygen desaturation is the most common complication occurring during intubation in the ICU, and it is the most common reason for aborting intubation attempt. Therefore, proper pre-oxygenation is important to prolong the time to desaturation during intubation and to increase the chance of first attempt success at intubation. So for pre-oxygenation, pre-oxygenation can be done by use of NIV and high flow nasal cannula. So regarding NIV, 3 minutes of pre-oxygenation using non-invasive positive pressure ventilation delivered by an ICU ventilator using face mask. The mask is more effective at reducing desaturation than by face mask with bag and reserve. Now the next device that we can use for the pre-oxygenation is high flow nasal cannula. The high flow nasal cannula oxygen delivered at 70 liters per minute through device capable of providing heated humidified oxygen. So this Miguel Montes et al. Showed that high flow nasal cannula oxygen administered at the flow rate of 60 liters per minute for pre-oxygenation and continued during intubation reduces the incidence of desaturation from 14% to 2% compared with non-breather face mask pre-oxygenation. And after pre-oxygenation with the non-invasive positive pressure ventilation, the addition of high flow nasal cannula oxygenation during attempt at tracheal intubation significantly reduces the severity of desaturation. So which one is better? Should we use NIV or should we use high flow nasal cannula? So when comparing the efficacy of high flow nasal cannula with NIV, the severity of the hypoxemia was considered, and regarding this, the Florali 2 trial was published. In that, they found that when they have used NIV, the NIV versus high flow nasal cannula, the incidence of desaturation was less with the help of NIV. So the final conclusion of Florali 2 trial was NIV in comparison to high flow nasal cannula alone helped to decrease the episode of severe hypoxemia during intubation procedure of ICU patient with hypoxemic respiratory failure requiring mechanical ventilation. Now, regarding this, the Optenu trial was published, which explored the combination of high flow nasal cannula and NIV in 50 patients with mean PF ratio of 122, and they have found that patients receiving the combination of combination intervention maintaining the high SpO2 during intubation than those with the NIV only group. So next concept is the apneic oxygenation. Apneic oxygenation provided through high flow nasal cannula during laryngoscopy may decreases the desaturation during intubation and may lead to higher first attempt success without hypoxemia. And the use of apneic oxygenation by simple nasal cannula at 15 liters per 50 liters per minute to prolong the duration of safe apnea after administration of neuromuscular blockage have been advocated in the emergency department. However, a recent randomized trial did not show any benefit of apneic oxygenation during tracheal intubation in critically ill patient because the effectiveness of apneic oxygenation in critically ill patient may be limited by presence of illness causing a physiologic shunt. Recently, the addition of supplemental oxygenation through nasal cannula in presence of mask leak has been shown to improve end-tidal O2 during pre-oxygenation. Now, sometimes the difficult situation arise because of the critical position. So the optimizing position is the key. So how to optimize the position? So the angle of the jaw should be the level of the top of the chest and with the ability to tilt the head back. So in simple language, I'll call it as sniffing position is the ideal position for the intubation. And what is this sniffing position is well described in this large diagram, which is labeled as diagram C. So we can see here pharyngeal axis, laryngeal axis, and the oral axis are aligned. And by using this sniffing position, we can reduce the distance between the teeth and the oral airway, and we can visualize the trachea very well. So the RAM position we are using, if we find the patient is obese and with the short neck, so by using this RAM position, we can align the mastoid process with the level of the top of the chest, and we can visualize the airway easily. So these are the two scenarios. So in figure 9, we can see the CPR is going on and the operator is trying to intubate the patient, but the intubator cannot reach the airway because of the constant movement. And the patient is also not in sniffing position. So what should be done in this situation? So in this situation, we can stop the CPR, but this delay in the CPR should not exceed 10 seconds, and we should give the stationary position of the head to the operator to facilitate the intubation process. Then the next in the figure, then in next figure, the patient is lying down on the floor, and the operator has to intubate this patient. So what are the challenges in this position? The position is awkward and relies solely on the forearm strength, and we cannot and the weight of the head pulls you off the balance. So what we can do in this position, we can fix the head of the patient between the legs, and we can try this intubation process. Now this is the video which demonstrates the RAM position. So I hope you guys are clear with the positioning. The next concept is the hemodynamic stabilization. So hypotension after intubation is reported in nearly half of the intubated patient in ICU with cardiovascular collapse occurring in 30% of the patient. And hemodynamic instability is the independent predictor of death following intubation. So peri-intubation hemodynamic instability has been shown to increase ICU stay, and also it contributes to the hospital mortality. So it is very important to optimize the hemodynamics before intubation. So the studies highlight the importance of fluid resuscitation in critically ill patient along with pre-oxygenation to improve the safety of emergency intubations. In addition, preparedness and the prompt treatment of post-intubation hypotension with vasopressor and further fluid therapy are important. Although the adequate fluid resuscitation can help prevent post-intubation hypotension, proper selection of the drug for intubation is equally important. So it is necessary to keep to optimize the hemodynamic before intubation, but even after intubation, we should make sure that the hemodynamics are stable. So for that, the selection, it is we need to wisely select this intubation drugs. So the drugs such as benzodiazepines, propofol, and thiopentol may be used in reduced doses. However, they decrease the systemic vascular resistance and produces the myocardial depression, and it may cause the precipitous fall in the blood pressure. So these are the various drugs that we are using in the rapid sequence induction process. So the first drug that they are using is the etomidate. The advantage of this drug, it provides the hemodynamic stability, and it has a rapid onset of action, that is 15 to 45 seconds. And the disadvantages, it is responsible for the cardiorenal insufficiency. The next drug that we can use is the ketamine. It will provide the more hemodynamic stability. It will also has the advantage of bronchodilatory effect. It has a good analgesic effect, and it has a rapid onset of action, that is 45 to 60 seconds. And the disadvantages, it will cause the hallucination. The next drug that we can use is propofol. And the advantage of this drug is, again, it has a bronchodilatory effect, it has a rapid onset of action, it can be used as anti-epileptic, and it has a better suppression of the upper airway reflexes. And the disadvantages, it will cause the hemodynamic compromise. Then for neuromuscular blockers, we can use either succinylcholine and the rocuronium. Succinylcholine has the rapid onset of action, that is 45 to 60 seconds. It improves the blottic visualization, and the disadvantage associated with these drugs are there is always risk of hyperkalemia, anaphylactic risk, and it has an increase in oxygen consumption. Then the rocuronium doesn't have any risk of hyperkalemia, and sugammadex can be used as the antidote for rocuronium, and it has a less rapid onset of action, that is 45 to 90 seconds, and anaphylactic risks are there for rocuronium also. So drugs such as etomidate and ketamine are preferred in ICU, although there are some concerns like transient adrenal insufficiency with etomidate, especially in septic patients. But there is no convincing evidence of the etomidate causing adrenal insufficiency. Now, the ketamine, due to its sympathomimetic effect, helps in maintaining blood pressure during intubation. So when compared to etomidate, there was no difference in the rate of complication. So again, ketamine may cause hypertension, tachycardia, increased airway secretion, raised intracranial and intraocular pressure. So unless contraindicated, it should be preferred induction agent for endotracheal intubation. So other agent that we can use is opioids, Dexam, lignocaine, as an adjunct to blunt the sympathetic response to the laryngoscopy. So as I mentioned earlier, so ketamine and etomidate are the preferred drug. So there are studies which compared the which one is the preferable, ketamine or etomidate. So there is a meta-analysis that was conducted regarding this, and the conclusion of this meta-analysis was that it showed the moderate when the induction with the ketamine was associated with the reduced risk of the mortality. Now the next is the role of neuromuscular agent. The use of neuromuscular blocking agent not only improves the laryngoscopic grade of the view, but also the overall intubating condition. And the use of neuromuscular blocking agent has been shown to improve the first attempt intubation success with both rapid and delayed intubation, irrespective of choice of induction agent and route of administration used. So, suxamethonium has been conventionally used neuromuscular blocking agent of choice unless contraindicated due to its fast action of facilitating early intubation without the need of ventilation. However, rocuronium at the dose of 1.2 mg per kg has a comparable speed of action and intubating condition when compared to the other agents. Now the next is device selection. So which device we should use, whether we should go for the laryngoscope or video laryngoscope. So although more widely used in operating table, the video laryngoscopy has been shown to increase first attempt success and improve glottic visualization during intubation in ICU, EDs and other pre-hospital setting, even in patient with the difficulty. So there was one meta-analysis which was conducted by De Jong et al. Comparing the direct laryngoscopy with video laryngoscopy for tracheal intubation in ICU, and it showed that the first attempt success was twice as they have used the video laryngoscopy. So this was the trial which was published in the NEJM in June 2023, and they have found in emergency situation when the video laryngoscopy has the high incidence of successful intubation than the direct laryngoscopy. And this is the next trial which compared the effect of the use of endotracheal tube and stillate versus endotracheal tube alone on first attempt intubation success. And the conclusion of this trial was this was the multi-center randomized trial involving critically ill adult patient undergoing tracheal intubation, and the use of stillate for tracheal intubation was safe and resulted in significant high first attempt intubation success than the use of tracheal tube alone. So this is the video demonstrating the use of video laryngoscopy. So which laryngoscope we should use? Whether we should go for direct laryngoscopy or video laryngoscopy. So what are the recommendations are? First, we assess for the difficulty of the intubation. That we can calculate it by the Macocha score. If the Macocha score is less than 3, and if we feel that this airway is not difficult, then we can go for the direct laryngoscopy. But if we have already predicted that the intubation is going to be difficult and also the Macocha score is also high, then the better to go for the video laryngoscopy. Now there are 10 tips to improve the first attempt intubation success rate with the video laryngoscopy. So the operator should be trained and at least he should perform the 15 intubation using video laryngoscopy. Then there should be the use of predefined airway management algorithm. Then we should carefully assess the difficulty of intubation before intubation using the Macocha score. Then the choice of a single video laryngoscopy device. Then patient should be adequately pre-oxygenated. Pre-oxygenation should be adequate for limiting hypoxemia and rush during the procedure. Then carefully suctioning should be done to prevent the secretions. Then rapid sequence induction with the use of neuromuscular blockers. Use of the stillate and the bougie should be ready, and to allow the easier intubation of the trachea, permit the suboptimal optimization of the glottis. Then the next is after deciding everything about the pre regarding oxygenation, drugs, and the device that we are using for the intubation, we proceed with the rapid sequence intubation. Now the most of the ICU patients are considered to have full stomach, and securing the airway with the rapid sequence intubation is the logical step. So either suxamethonium or rocuronium may be used for neuromuscular blockage, and the application of cricoid pressure may make the laryngoscopic view unfavorable. So in such a situation, cricoid pressure should be partially or completely released to improve the laryngoscopic view or later reappear. So gentle mask ventilation while applying cricoid pressure before tracheal intubation can prolong the time to desaturation and may be useful in patients with poor respiratory reserve and sepsis. A second generation supraglottic airway device offers the greater protection against the aspiration as compared to the first generation devices and should be inserted if tracheal intubation fails during rapid sequence induction. Insertion of supraglottic airway insertion may be difficult if cricoid pressure is applied and thus should be released during insertion. Now, there are 7 P's for the rapid sequence intubation that we should know. The first is preparation, then the pre-oxygenation, pre-treatment, dialysis with sedation, positioning, placement of the tube, and post-intubation management. Now, after putting tube, the next vital step is the confirmation of the tracheal intubation. The studies have shown that the failure to use capnography contributed to 17 deaths in brain deaths or the brain damage in ICU. And the esophageal intubation and accidental tube displacement accounted for 82% of events leading to death or brain damage. And this report strongly recommended the use of capnography for confirmation of tracheal intubation in all critically ill patients, irrespective of location. Now, the next is next thing that we need to take into consideration are the human factors and training. So, intubation in ICU is required at any time in day or night, or may often be performed by less experienced practitioner. So, in addition, considering the altered physiology of the critically ill patient, lesser time to desaturation, and higher risk of complication, these intubation may lead to very stressful situation, which may compromise the performance of operator sometimes. Thus, the airway management training should be the integral part of the training of any specialty which deal with the critically ill patient. The use of simulation-based training will help enhance both technical as well as non-technical skill and improve the preparedness for highly stressful situations. And the use of algorithmic approach in the intubation bundle may further improve the performance. Now we'll see what is the intubation bundle, which will help us in dealing with this situation skillfully. So these bundles are structured way of improving process of patient care outcome using small and straightforward set of evidence-based practices, which when performed collectively and reliably have proven to improve the patient outcome. So adherence to this protocol resulted in significantly lesser life-threatening complications such as severe hypoxemia, severe hypotension or cardiac arrest, and also mild to moderate complication compared to conventional strategy. So the bundle has 10 components, which include the presence of at least 2 operators, then fluid loading with 500 ml of saline, preparation of long-term sedation, and pre-oxygenation for 3 minutes with non-invasive ventilation, 100% oxygenation, then pressure support ventilation level between 5 and 15 centimeter of water to obtain expiratory tidal volume between 6 to 8 ml per kg. Then the PEEP should be 5 in case of acute respiratory failure in pre-intubation period. Now, rapid sequence intubation is performed using cricoid pressure with either ketamine or etomidate for induction and suxamethonium or etomidate for neuromuscular blockage. Then post-intubation component include immediate confirmation of tube placement using capnography, using norepinephrine if diastolic blood pressure is low, and initiation of long-term sedation and use of protective lung ventilation. Then there is a stepwise approach for the management of tracheal intubation in intensive care unit, and it is published by All India Difficult Airway Association. So it is important to remember that while following any step in the algorithm, if oxygen saturation is not maintaining or start rapidly falling, or if in case bradycardia develops, then one can bypass one or more steps and directly proceed to the rescue ventilation or even emergency cricotherapy. So step 1 is the pre-oxygenation and induction of anesthesia. So during induction, the presence of minimum 2 persons is required. Out of 1 should be experiencing airway management. So the next step is pre-oxygenation. Pre-oxygenation should be done using non-invasive ventilation with pressure support ventilation level between 5 and 15 to obtain the expiratory tidal volume between 6 and 8 ml per kg and PEEP of at least 5. Uh, nasal cannula with O2 flow of 15 liter per minute may be used in addition when there is a mask. Then in case if you are using high flow nasal cannula, then it should be used with 70 liter per minute of oxygen flow. Pre-intubation fluid loading should be done with 500 ml of saline in the absence of cardiogenic pulmonary. The patient should be anesthetized using ketamine or etomidate, or neuromuscular blockage can be provided with succinylcholine or roperidone. Then positive pressure may be performed using bag mask with reservoir bag using external PEEP of 5 to 10 if available, or using ventilator maintain the required pressure throughout. Required pressure should be given but may be partially or completely released if ventilation is inadequate. Then the next step two is laryngoscopy and tracheal intubation. If mask ventilation is successful, then proceed with tracheal intubation using direct or video laryngoscopy. Nasal oxygenation within the O2 flow of 15 liter per minute and high flow nasal cannula of O2 should be continued. Do not exit more than 2 attempts at intubation and repeat attempt only if saturation is more than or equal to 95%. Mask ventilation should be performed between the attempts. Then position should be optimized. Use external laryngeal manipulation, partially or completely release the cricoid pressure to optimize the laryngoscopic view if required, and if needed, use bougie or stick. And between the attempts at intubation, consider changing the device or technique rather than repeating the same thing. Then maintain the depth of anesthesia throughout the intubation process. If mask ventilation is not possible, a single attempt at intubation could be made, provided the saturation should be well maintained. And after intubation, confirm the proper ET tube positioning using capnography along with the clinical values. Now, the third step is insertion of supraglottic airway device. If 2 attempts of intubation is failed and after a single attempt of intubation following unsuccessful mechanical ventilation fail, then it is recommended to use supraglottic airway device to ventilate the patient to maintain the level of oxygenation. Note, not more than 2 attempts should be made to insert the supraglottic airway device, and we should make sure that oxygenation level should be more than or equal to 95. And or we can continue with the nasal oxygenation using the O2 flow of 15 liter per minute and high flow nasal cannula during the insertion of these supraglottic airway devices. Now we should perform the mask ventilation between the attempts. So consider if we are failing with the one type of supraglottic airway device, then we can change the type and size during the second attempt. And we should make sure that the depth of the anesthesia should be maintained throughout this attempt. So once supraglottic airway device insertion is successful and oxygenation is maintained, then consider performing percutaneous or surgical tracheostomy for further airway management. Or we can intubate through that supraglottic airway device under the vision using flexible fiber optic bronchoscopy. And intubation should not be attempted blindly through supraglottic airway devices if bronchoscope or and the other expertise help are unavailable. Then the step 4 is the rescue face mask ventilation. If ventilation through supraglottic airway devices fails, then we should then continue the nasal oxygenation using O2 flow or high flow nasal cannula. And during the procedure, ensure the complete neuromuscular blockage and repeat a muscle relaxant if required. Give one final attempt at face mask ventilation using optimal technique and adjunct. If rescue mask ventilation also is successful, then proceed with the percutaneous or surgical tracheostomy. However, if rescue ventilation is unsuccessful, then there is complete ventilation failure, and in that case, Continue with nasal oxygenation using oxygen flow at 15 liter per minute and high flow nasal cannula and call for the additional help. Immediately start performing emergency cricothyrotomy before patient desaturate further. Now the stepwise emergency cricothyrotomy. Perform emergency cricothyrotomy using needle and surgical cricothyrotomy based on the familiarity and availability of the equipment. If needle cricothyrotomy is performed, maintain the oxygenation using pressure regulated jet ventilation until tracheostomy is performed. If wide bore cannula cricothyrotomy set has been used or EP tube has been passed through front of neck, continue ventilation manually or using the ventilator circuit. Now, this is the video demonstrating the cricothyrotomy procedure. So we'll quickly revise what are these All India Difficult Airway Association guidelines. So at least 2% should be there. Then we should optimally pre-oxygenate. Pre-oxygenation should be optimal. Then we should administer the correct sedation and paralytic agent. For that, we can use either intermediate ketamine or succinylcholine or rocuronium. Then use the proper cricoid pressure and give the positive pressure ventilation with and PEEP should be between 5 to 10. Now, if face mask ventilation is unsuccessful, means if the patient is not ventilating properly with face mask, then give the only give single attempt of tracheal intubation. And if the patient is properly ventilating, then we can proceed with the 2 attempts. And if we are successful in that attempt, then we need to confirm the position of the tracheal intubation using capnography. But if we fail in that attempt, then the next step is to use supraglottic airway devices. So while using supraglottic airway device, make sure that we are using the second generation supraglottic airway device and we are maintaining the oxygenation level above 95% when we are using this. And if we are failing in the one attempt, then while attempting for the second time, we should change the size, change the device, and also change the size. And if you are success and with the help of this supraglottic airway device, if you are succeeding in that attempt, then the next step is to go for the surgical tracheostomy or attempt the intubation through the supraglottic airway device. And if you are failing if you are unable to maintain the ventilation through the supraglottic airway device, then the next step, that is step 4, is to rescue face mask ventilation. And if you are failing in that attempt also, then there is a complete ventilation failure. Then the next step is to go for the emergency cricothyrotomy. So this is the Montefiore intubation protocol. So the pre-intubation, 2 operators are needed. We should load a patient with the fluid of at least of 500 ml if the patient is not in cardiogenic pulmonary edema. Then long-term sedation is required for pre-oxygenation. Consider the patient head end should be elevated, that is 20 to 30 degree. Then give the pre-oxygenation at least for 3 minutes with the NIV, preferably with the NIV. Then the use, if we know the to be difficult, then it is better to make use of video laryngoscope. Then perform if you are in ICU, then perform the rapid sequence intubation. You make use of Selic maneuver. Then make sure that saturation is more than 95% throughout the procedure. And post intubation, for confirming the position of the tube, make use of capnograph. Post intubation also, we should make sure the hemodynamics are stable. If the patient is becoming hypotensive, make use of vasopressors and inotropes. Then start early long-term sedation. Airway pressure should be low. Then use the lung protective ventilation. If patient is not maintaining oxygenation, go for the recruitment maneuver, and the cuff pressure of the tube should be between 25 to 30. So these are some take-home message. So check every patient for difficult intubation. Not every patient in distress need intubation. So there should be the proper teamwork, and the communication are the two essential part in tackling the situation of the difficult airway. If airway looks difficult, consider awake intubation. People, place, and thing. Gather your resources. Sometimes the airway is not difficult, but the position is critical. And do not ignore the physiologically difficult airway. And my colleague, Dr. Neeraj, will talk more on that. So over to you, Dr. Neeraj.
So first of all, thank you, Dr. Ashwini, for this extensive presentation. And so most of the points have been covered. So the thing is that sometimes even after repeated, telling all these points, actually, sometimes when you actually do the things practically on the bedside, it becomes very difficult sometimes if you particularly means encounter an unanticipated difficult intubation. And the intubation in the ICU is totally different from that of the OT, because OT is a controlled environment. So when these difficult airway guidelines are first placed by the American Society of Anesthesiologists in 2012, and then 2013, it has been came into the action. And the recent modified guidelines in 2019, basically, so every guidelines has stressed the importance of assessment of the risk in a patient. So what are the risks that that particular patient is at risk of difficult intubation? So is already in the ICU, the assessment of the risk become more difficult, because the patients are critical, the hemodynamics are continuously changing, the position is sometimes very difficult. A lot of times we cannot give a head low, we cannot give a lot of other positions which is very suitable in the OT environment, and actually we don't have sometimes lot of gadgets surrounding the patient also. So that is the reason. So that ICU intubation is more and more challenging, and the one has to anticipate and one has to prepare. And every ICU, what I suggest is to have a proper intubation kit and checklist. So just like a crash cart, intubation checklist and intubation kit should be always available. And whenever there is a slightest anticipation of any difficult airway, and the kit should be immediately brought, and the checklist should be given to the senior most nurses, and the patient should be immediately be prepared in the right position, because in ICU the position is very vital. So because sometimes you need to lower down the edge of the all your railings of the bed, you have to take out the head end of the that railings of the bed, and sometimes this instruction your senior nurses has to be aware of when one has to particularly deal with an emergency unanticipated difficult intubation. And with every passage of time, when you see that the saturation is dropping, the blood pressure is dropping, the heart rate is dropping, and that is the time where the decisions has to be quick, and it has to be a very vital actually. So without wasting much time, that time you have to have a better laryngoscope, particularly video laryngoscope, your LMS, which will help, particularly the second generation LMS. And that time the most experienced your specialist should be in the head end actually, rather than giving the chance to the juniors. That time your most experienced person, particularly a consultant or a senior consultant, should be in the head end to save the patient. And always remember that it is not the intubation, it is the ventilation. So by somehow you have to maintain the oxygenation to the maximum possible extent. If you have a facility for HFNC, you put the HFNC. If there is slight doubt that this patient is going to have a difficult intubation, or you can directly put on NIV. Achieve a good oxygen level, achieve a good pre-oxygenation. I can say if the oxygenation is maintaining, do a good pre-oxygenation for 5 to 7 minutes. No harm in that. And particularly sometimes you put the nasal prongs, put the NIV, and then put the proper position, and then you make the things ready. Keep the checklist ready. And capnometry should be the key actually. Every intubation in the ICU should be guided by your post-intubation capnometry to monitor whether the tube is in the proper trachea or in the esophagus. That is the most important thing. And of course, now with the advance of all the ultrasound, you can before intubation, every patient, when you suspect any patient who comes to the ICU, you suspect that it is a difficult intubation, you can do a ultrasound of the neck, ultrasound of the muscles, or ultrasound of the different anatomical structure of the neck to just have a rough idea. And particularly the measurements, just not a accurate measurement, but a rough measurement of all your distances, like the thyromental distance, the thyroid distance, the neck anatomy, the obesity, the BMI, and it's a routine protocol to measure the BMI, their body weight, and it's everything in the ICU. So any obese patients, and always alert your team. It's a team effort. Alert your surgeons, alert your ENT surgeons, your onco surgeons. If there is an onco case, sometimes most of the times it is difficult when the patient will extubate, and sometimes they go into against stridor. You cannot able to intubate, and that time always during extubation, tell your onco surgeons or your colleague to be around, so that any kind of difficulty they can immediately do a tracheostomy. And we have encountered a lot of such cases actually where sometimes the patient emergency tracheostomy need to be done, particularly in difficult high risk patient. So that is the reason it's a basically anticipation is the key actually. Risk assessment is the key actually, and best to best available of equipment, particularly the CMAC, the bronchoscope, and the video laryngoscope. These are the three like the pillars of success whenever you are anticipating any difficult intubation. And of course, not to forget the basic things like your LMAs, second generation LMA, and a good pre-oxygenation to save the patient of life whenever you are in difficulty. Always start vasopressor early, because most of the patients they crash. So do not wait for the blood pressure to go down, because that is again pose a different challenge. So now we'll hear from the Dr. Neeraj. So what are the physiological challenges, particularly in ICU patients? Yes, Dr. Neeraj. So I request Dr. Neeraj to upload the slides. And any questions, please put on the chat box so we can take and we can discuss.
Are my slides visible?
Yes. Make it in the slideshow
sir.
mode. Actually.
Yes, sir. Thank you, sir, and thank you all thank you everyone for giving me the opportunity to talk on a very important and critical topic in the ICU, which we deal with every day. So I will be discussing on management of physiologically difficult airway. So the we label it a physiological difficult airway when physiological characteristics make it difficult to safely induce the patient and transition to positive pressure ventilation. So the four major physiological processes which we have to understand and which are there in the process to call it a physiological difficult airway are first is vasodilation and loss of sympathetic tone. So whatever drugs we are using in the ICU, be it pseudoanalgesics, be it induction agents, be it NM blockers, they all eventually lead to hypotension, which can be very precipitous hypotension and patient can end into cardiac arrest. Second is acidosis, hypoxemia, hypercarbia. So the more the patient goes into apnea because of lack of pre-oxygenation, because of poor oxygen reserves, the more the patient will end into the vicious cycle of this acidosis, hypoxemia, hypercarbia, and that will lead to decrease in SVR, rise in PVR, and decrease in cardiac output. Then whatever airway we are manipulating, it will lead to increase in intracranial pressure. So especially in the patients with traumatic brain injury, this can be deleterious, and it can further lead to increase in ICP and can lead to coning if the pressures are very high and not compatible with the cerebral perfusion pressure. And then when we induce the patient and put on the ventilator, that is IPPV, so that can also lead to decrease in effective preload and lead to decreased cardiac output, especially in patients who have pericardial tamponade, which we don't know, and which is a patient who is a preload dependent patient. So these four mechanisms are very important for any patients which we deal in the ICU while intubating a case of physiological difficult airway. So I'll be going through real-time case scenarios which we deal in the ICU and what problems do we encounter while dealing with some patients. So 55-year-old male with known cirrhosis, liver parenchymal disease. He is admitted with upper GI bleed, is in shock with severe anemia, who has yet to receive blood products. When he suddenly has a marked decrement in mental status, a drop in SATs, and he requires a secure airway. So the problem is here that you need to do everything in your power to provide some resuscitation to defend the map prior to intubation, who will otherwise be significantly impacted. It is likely arrest as a function of induction and institution of positive pressure ventilation due to intravascular depletion due to active hemorrhage. So here it will be a life-threatening situation to, you can say, induce the patient, intubate the patient, because already patient has worsened in terms of its encephalopathy, is hypotensive, is very intravascularly depleted, and is having active hemorrhage. So We have to maintain the map at all times before induction, after induction to maintain end organ perfusion. Then this is a 31-year-old man with diabetic ketoacidosis with severe pH of 7.1 with a PCO2 of 15, who is stable initially, but suddenly he decompensates with a repeat pH of 7, PCO2 of 45, lactate of 7, while looking like he is tiring out. So the problem here is he's having severe acidosis that places the patient at high risk during intubation because the apneic interval can cause a low pH to drop to very perilous level and lead to cardiac arrest. Then this is a 42-year-old male with acute pulmonary edema, pulmonary embolism, originally classified as submassive. He was stable initially, but then he develops into a massive pulmonary embolism with a shock state. He collapses BP 80 by 40, complicated by respiratory distress, worsening mental status. So this is a case of intubating in the settings of RV failure, which is acute onset RV failure, and all of the pseudoanalytics and induction agents which we discussed, they will cause drop in preload on which the RV is totally dependent, and it will lead to LV failure due to interdependence and effectively reduce cardiac output and arrest. So these are very life-threatening situations we deal in the ICU, and they have to be tackled very smartly. We have to use very titrated dose of induction agents, give fluid boluses, then maintain MAP at all times. So this was a very good recently published article in by LC Burko in Anesthesia Journal of American Anesthesia Journal, the physiologically difficult airway and management considerations. So physiological difficulties of tracheal intubation is in critically ill adults have become a new focus of interest. These patients typically require definitive airway management due to organ dysfunction or other manifestations of critical illness like altered consciousness, respiratory failure, and shock. So these and other pathophysiological states increase the risk associated with sedative, hypnotics agents and their hemodynamic sequel, apnea during tracheal intubation, and or transition to PPV as already described. So therefore, successful airway management in critically ill adults require planning and execution of strategies that mitigate potential technical and physiological difficulties. So which patients are at risk? So recognizing that the risk associated with airway management may be due to technical or physiological difficulties, predicting adverse outcomes require consideration of both factors. So this was exemplified by the MACOCA score, which we commonly use in the ICU, which include both anatomical and physiological features to predict difficult intubation and has been incorporated into relevant guidelines. So risk factors for cardiovascular collapse, that is cardiac arrest, have been also be explored. In a secondary analysis of the cohort used to derive and validate the MACOCA score, Perbert et al. Identified advanced age and more severe critical illness as risk factors for cardiovascular collapse. So subsequently, De Jong et al. Identified hypotension, hypoxemia, lack of pre-oxygenation, obesity, and advanced age as relevant risk factor for cardiac arrest. So Holiday et al. Identified hypotension, the need for vasopressors prior to intubation, age, and cirrhosis as top 4 risk factors in a secondary analysis trial of data for risk factors for adverse cardiac events post-induction. So right ventricular dysfunction is also an increasingly appreciated risk factor as perturbations in gas exchange, acid-base status, and intrathoracic pressure may all lead to cardiovascular collapse. In a secondary, so this was a in-tube study. In a secondary analysis of in-tube study, the risk factors for cardiovascular instability included age, lower blood pressure before induction, lower oxygen saturation, and propofol administration. So what about hemodynamic optimization before induction and after induction? Given that cardiovascular instability is a primary risk for tracheal intubation in critically ill adults in the contemporary era, its prevention and management is a natural clinical focus. Furthermore, cardiovascular instability, among other adverse peri-intubation events, has been independently associated with ICU mortality. So, what about an optimal induction agent? Has already been covered by my colleague, but I will again brush through it. So, the optimal induction agent, if any, for tracheal intubation in critically ill adults remain controversial. Let's see what literature is saying. So, a famous intube study. In this observation of intubation practices in critically ill patients, major adverse peri-intuition events, in particular cardiovascular instability, was observed. So propofol was the induction agent commonly used in the ICU, that is 41.5%, followed by midazolam, etomidate, and ketamine in that order. So in the secondary analysis of intube, an inverse probability of treatment weighing approach to causal effect interference suggested that propofol administration was the sole variable independently associated with cardiovascular instability or collapse. Etomidat and ketamine have been recommended as first-line induction agents in critically adults because they have some neutral or less BP offsetting properties as compared to propofol, but they have to be taken with a pinch of salt because etomidat can also cause drop in the BP, especially in septic shock patients. Adrenal reserves and ketamine can cause rise in ICP, which is obviously transient, but then they have to be weighted against the risk versus benefit ratio while using in the patients for induction. So the comparison between etomidat and ketamine was done by EVIC trial. So Matchet et al. Recently reported that results of etomidat versus ketamine for emergency endotracheal intubation EVK trial, in which 801 patients were randomized to receive either etomidat or ketamine for emergency tracheal intubation. Among patients who received ketamine in the EVK trial, 25% sustained post-intubation cardiovascular collapse versus 17.4% who received etomidat. So what is the role of fluids? While tracheal intubation is one of the most common ICU procedures, fluid administration is among the most common intervention which is done to decrease the incidence of hypotension upon induction and to maintain the mean arterial pressure upon induction. So recognizing the risk of hypotension due to induction agents and or transition to PPV, fluid administration prior to intubation has reasonable physiological rationale. So vasodilation from induction agents may be offset and venous return to the heart can be increased even amid increased intrathoracic pressure. However, favorable clinical effects have not been borne out in two trials. So this is a famous PREPARE trial, which is an intravenous infusion of crystalloid fluid bolus does not decrease incidence of cardiovascular collapse during tracheal intubation. So 1067 critically ill adults undergoing tracheal intubation at ICU in the US were enrolled. They were enrolled in two groups. One group was did not receive any fluid bolus, and the second group received 500 ml fluid bolus. So the primary outcomes were that fluid bolus group and no fluid bolus group. They compared the incidence of cardiovascular collapse and hypotension between the two groups. So among critically ill adults undergoing tracheal intubation, administration of intravenous fluid bolus compared with no fluid bolus did not significantly decrease the incidence of cardiovascular collapse. So you have to titrate individually according to the patient characteristic. You have to do a point of care ultrasound also to look for IVC and other parameters. So not only relying on standard fluid practices that I have to give only 5 ml bolus and then that will help to mitigate the blood pressure. So you have to assess the patient from patient to patient basis. So in PREPARE 2 trial, the impact of 500 ml of crystalloid bolus on the primary outcome of cardiovascular collapse examined, there was no significant effect. But there was suggestion of benefit in patients who received PPV during intubation with NIV or bag mask ventilation. Because these patients on NIV and bag mask ventilation, they have some amount of aerophagia and gastric dilatation, which can lead to hypotension. So they may benefit from some amount of fluid administration. Other things the trial did not have in favor. That is, you may have to assess the patient on individual basis before giving the fluid bolus to offset any fall in the BP upon induction. So what is the role of vasopressors? Evidence to inform optimal selection and approach to vasopressor is lacking. However, given that cardiovascular instability accompanies a substantial proportion of tracheal intubation, it follows that the immediate availability of vasopressors should be included as a part of routine preparation. Whether administered preventively or in response to hypotension, the immediate readiness of these agents guarantees a short time between the development of instability and treatment. Vasopressors have been included and studied as elements of peri-intubation bundles, and a trial is underway to compare the efficacy of preemptive vasopressor agents against the fluid bolus. What about hypoxemia? It's a very challenging thing when you encounter a patient with physiologically difficult airway. Hypoxemia is the second most common adverse event followed by cardiovascular event with tracheal intubation in critically ill adults. So at all times, our primary aim is to maintain oxygenation. So maintaining adequate oxygenation between induction and intubation, sometimes called the apneic interval, is a key element of safe airway management. Acute or chronic lung disease coupled with concerns about aspiration serve to limit the efficacy of traditional pre-oxygenation strategies, and they diminish our enthusiasm for certain rescue approaches. So our standard pre-oxygenation strategy is adequate. Conventional pre-oxygenation.
Dr. Neeraj,
Yeah, tell me.
hello.
Bolo na madam.
Yeah, you have to speak a bit loudly. I think your voice, if I'm not able to hear or everybody is.
Is my voice audible to all others?
It is very, I can hear it, but it is.
So a little louder.
Voice.
A little louder, please.
Okay. Our standard pre-oxygenation strategy is adequate. Now I'm audible properly.
Be close to your microphone actually.
Hello. Now I'm audible properly.
Yes.
Okay. Our standard pre-oxidation strategy is adequate. So conventional pre-oxidation approaches often do not meaningfully extend the safe apneic interval, particularly in patients with gas exchange at baseline. Secondary analysis of airway management trial data have revealed a nearly linear proportionate relationship between SpO2 and induction and the lowest SpO2 during tracheal intubation. So this was exemplified in a study by Mott et al., in which 34 consecutive critically ill patients were pre-oxygenated prior to tracheal intubation with 100% inspire oxygen fraction through an adult resuscitator bag for 8 minutes with serial ABG analysis. From 0 to 4 minutes, the mean PaO2 increased from approximately 62 millimeter to 84 millimeter, and from 4 to 8 minutes, the mean increase was only 9 millimeter, with a quarter of patients demonstrating a reduction in PaO2 likely due to atelectasis. So what about NIV? NIV has been associated with improved oxygenation during tracheal intubation with fewer adverse events compared to conventional pre-oxygenation. Positive pressure likely helps overcome the absorption atelectasis that develops during pre-oxygenation with high FiO2 and unsupported spontaneous breathing. Despite these advantages, InTube showed that NIV was infrequent in clinical practice, although not all patients may require advanced approaches to pre-oxygenation. So another is that the mask interface must be removed prior to airway instrumentation, at which point oxygen delivery is interrupted. Finally, NIV may risk gastric insufflation and aspiration, which will be discussed subsequently. What about apneic oxygenation? This is very important part because our efforts to maintain the oxygenation at all times is very important. High flow nasal oxygen offers the advantage of an unobstructive nasal interface that can be maintained during airway management. Therefore, high flow nasal oxygen is one modality by which we accomplish both pre-oxygenation and apneic oxygenation during airway management. So when comparing the efficacy of high flow nasal oxygen with NIV, the severity of baseline hypoxemia must be considered. In a Florali 2 trial, Frat et al. Reported that 24% of the patient pre-oxygenated with NIV developed a SpO2 less than 80% versus 35% who were pre-oxygenated with high flow nasal oxygen. The Optinif trial explored the combination of high flow nasal oxygen and NIV in 50 patients with a mean PF ratio of 122 and found that patients receiving the combination intervention maintained a higher SpO2 during intubation than those in the NIV only group. So what about Thrive? So this is a very famous article published in Annual Anesthesia Article of the Year Award. Transnasal humidified rapid insufflation ventilatory exchange versus face mask breathing pre-oxygenation for rapid sequence induction in adults, a prospective randomized non-blinded clinical trial. So hypoxemia upon induction still remains a significant problem and can have a dramatic impact on outcome. Although this study found no difference in lowest SpO2 between Thrive and face mask pre-oxygenation in adults undergoing rapid sequence induction, there was a lower incidence of patients desaturating below 93% in the group with Thrive. This last statistics indicates that Thrive may prevent hypoxia when apnea is prolonged due to difficulty with intubation. So here you are seeing an overview of the Thrive physiology. The image with rapid insufflation is a computational fluid dynamic model of an upper airway at the end of spontaneous expiration with 0, 20 and 60 liter per minute of nasal flow. So you can see at 60 liter of nasal flow, CO2 is entirely flushed out of the airway and 100% oxygen is shown in blue, is present at the immediate supraglottic area. This causes dead space flushing, preventing rebreathing and reducing upper airway resistance. So Thrive has many uses in the OT and ICU settings. It can be used to reduce oxygen reserve in pregnancy, sepsis, obesity, then for procedural sedation, that is EBUS, bronchoscopy, ERCP, ECT, laryngeal EMG, then difficult airway, increase apnea time during laryngoscopy for no decide purpose, anesthetic ENT procedures, especially microlaryngeal surgery procedures, surgical airway to reduce work of breathing in awake tracheostomy patients, then allow cautious sedation to reduce anxiety, hyperventilation, then the impossible airway triad, that is trismus, reduced neck movement, and pharyngeal stenosis. So it's a very important and useful tool in the ICU to maintain oxygenation while securing a tube. That is Thrive and no desat concept. Should mask ventilation be avoided at all times? Critically ill patients are at risk for aspiration and for potentially severe sequelae of aspiration in the presence of acute respiratory failure. So rapid sequence intubation, which avoids mass ventilation, has long been thought to help minimize the risk of aspiration, although the supporting evidence is limited. Furthermore, RSI itself may confer risk due to induction agent and dose and risk of hypoxemia in patients with severe respiratory failure. So nowadays, the concept of RSI has been changed to drug-assisted intubation. That is, we you minimally or we don't use NM blockers. We use induction agents and steroid analgesics for intubation, and the record pressure may or may not be applied for intubation in such patients, because sometimes the record pressure you have to also release because it can obscure your view of laryngoscopic view. So you have to intubate the patient while doing RSI. The PREVENT trial compared bag mask ventilation versus its avoidance during interval between induction and tracheal intubation in 401 critically ill adults with a primary outcome of lowest SpO2. SpO2 was higher in the bag mask ventilation group, and the incidence of SpO2 less than 80% was lower compared to the control group. The overall rate of reported aspiration was 3.2% group. Although not designed or powered to critically examine safety outcomes such as aspiration, the PREVENT result challenges the dogma that mass ventilation must be strictly avoided and supports clinicians who choose to employ bag mask ventilation to safely temporize hypoxemia during the apneic interval. So what about first pass success while intubation? No matter how robust the preparation, time for tracheal intubation may be limited. In the era before video laryngoscopy, multiple attempts at airway management were found to place patient at high risk for adverse outcomes. So in Intube studies, 2 or more intubation attempts were likely associated with increased risk for major adverse events. In particular, the risk of severe hypoxemia increased from approximately 5% with one attempt to more than 20% with two attempts, and to more than 30% with three attempts. So you have to always have a plan B while intubating the patients, because the more time you spend with the intubation, the more chance of patient having hypoxemic brain damage, permanent brain damage and all. And while dealing with video laryngoscopy, you have to be trained with the because it takes a learning curve to be used in situation, especially emergency situations. In ICU video laryngoscopy trials, video laryngoscopy also appears to be associated with improved first pass success, provided you have adequate expertise and training in that. And video laryngoscopy generally gives a superior view of glottis as compared to normal DL scopy. So here I will give a few algorithms for what are the possible mechanisms which you deal with and what we have to take actions because of that. This is a cartoon which shows the physiologically difficult airway and the art of peri-intubation resuscitation. So the 4 P's of initiating the resuscitation are pressure, pre-oxygenation, respecting the pH and pump. So the shock index, we have to predict danger before it happens. What if there was a way to identify patients at risk for peri-intubation hypotension and increased mortality? Fortunately, there is an increased heart rate and decreased BP prior to intubation predicts trouble. The shock index is a simple way to identify and quantify that risk. Pre-intubation shock index more than 0.8 strongly predicts post-intubation hypotension, and a shock index more than 1 is a predictor of 28-day mortality. So you have to calculate this prior to patient induction of the patient to prevent the deleterious effect of hypotension. So don't start down the road to intubation without checking the shock index. Then focus on pressure. Peri-intubation hypotension is an independent risk factor of cardiac arrest, longer ICU stay, and in-hospital mortality. Vasodilation, loss of intrinsic sympathetic surge, and increased intrathoracic pressure from PPV are all potential hazards of intubation. Learn how to avoid this risk and protect your patients from peri-intubation hypotension here. Obtain access, maintain MAP, try to do awake intubation, use low dose sedatives, maximize palliative agents, assess volume status, two peripheral IVs or big veins, external jugular vein, intraosseous, femorocentral line, IV fluids, then have a push dose pressor ready at your bedside, then peripheral pressors to be kept ready. Then pre-oxygenation algorithm in the patients with refractory hypoxia, all patient more than 3 minutes, nasal cannula and NRB at flush rate plus head end of elevation more than 20 degree or reversed trend position. So is still the SpO2 less than 93% after 3 minutes. So go for high flow nasal cannula, CPAP, PEEP wall or BMV. Patient is unable to tolerate mask. He is very agitated because of hypertension. You can go for delayed sequence intubation with the use of minimal sedation and palliative agents to prevent refractory hypoxemia and deleterious effect. Then respect to hydrogen ions, focus on acidemia. So as I had mentioned in the case before, Does your patient have deep, rapid respiration from severe metabolic causes? Ventilators are incapable of matching these patients' intrinsic minute ventilation, which puts them patients at increased risk of peri-intubation arrest. So you can buy time on the patient for the patient on NIV, correct the underlying metabolic cause. Don't hurry the patient for intubation, because the more the patient goes into apneic arrest, the more the patient will have a acidosis, CO2 build up, more the PVR, less the SVR, and the patient will have arrest. And check the pump, rapid assessment of right ventricle. Always focus on RV failure. In a critically ill patient, RV dysfunction, PPV can be a devastating 1-2 punch that can lead to cardiovascular collapse. Fortunately, the presence of RV dysfunction can be easily assessed with point of care ultrasound. In this space, we show you how to assess your patient's cardiac function to assist with resuscitation and peri-intubation planning. So this is the 4-chamber view. TAPSE view can be done to see the right ventricular function. Then contractility can be seen, and RV function can be assessed. So what about recent advances in airway management? So point of care ultrasound has come a long way, and we are using it to assess the patient's airway, to evaluate and manage the patient. It can be used for assessment of difficult airway, confirmation of proper endotracheal intubation, prediction of post-extubation laryngeal edema, preparation of a cricothyrotomy by identifying cricothyroid membrane. So here you can see the 5 views which we see on the focus. First is suprahyoid view, which tells us about the oral space assessment, the tongue, the thickness of tongue, then the thyroid membrane for epiglottis identification, then thyroid for vocal cord function, any vocal cord edema, vocal cord dysfunction, then cricothyroid membrane to plan for cricothyrotomy, tracheostomy, and then to confirm the proper tube placement, that is at this level. So here you can see the algorithm, as sir mentioned, the distances which we have to take into consideration while dealing a patient with difficult airway. So this is a thyroid view. The distance of skin to epiglottis is more than 2.5 centimeter. Yes, it is a predictor of difficult intubation. Then hyomental distance less than 5.29 centimeter, or TT more than 6.1 centimeter, it predicts difficult intubation. Then hyomental distance ratio less than 1.08, it also predicts difficult intubation. And then if it is less than 1.12, then it is normal airway protected. So these are very useful tools to assess the patient's difficult airway, to plan the patient's airway, and to assess the patients who are at risk for unanticipated difficult airway. So this is a view which shows us proper tube placement. So when the tube is in proper position, you have only one, you can say, echo view here with the posterior shadowing. If the tube is in the esophagus, you can see both tram track appearance, both ear shadows with less posterior echoing here and anteriorly. So this is the view where you can confirm the placement of proper tube placement. Then assessment of edema. So this is a anterior cuff to vocal cord ratio. So if the ratio is more than 0.9 in a normally inflated cuff, or if the cuff is depleted, and if ratio is more than, if the dimension is more than 0.72%, it indicates that there is edema and the patient is risk for development of post-extubation stuttering. You have to be very careful in extubating these patients. Then this is a cricothyroid membrane. You can with the astrocyst mark. Then you can see what is the dimension of the membrane. Is the membrane proper and not, to prepare for cricothyrotomy of the patient. So this is a nasal endoscopy. You can see the mass which is encroaching into the glottic area. So glottic mass in the glottic area. So nasal endoscopy is used to assess upper airway and trachea, and is useful for planning both tracheal intubation and extubation. It can also facilitate examination of devices in situ like SAD, tracheal tube, tracheostomy tube in situ, and can aid in extubation and device manipulation. So take home points. Airway can be anatomically difficult, physiologically difficult, or a combination of both. You can't predict what you will get in front of you. Physiologically difficult airways are often harder to spot, predict, and harder to manage. Intubation presents a number of physiological challenges to a critically ill patient that must be overcome through deliberate thought and planning. Using NIPP and aggressive pre-oxygenation are almost never bad ideas when it comes to providing as much oxygen reserve as possible prior to inducing and intubating. Call for help, always call for help. Have your team ready, always have a plan A, plan B. Have the tools at your armamentarium you are most comfortable and with you, and have a plan ready. Try to avoid intubating patients in absolute extremities if possible. If you can start maintaining them on NIV, and use the patient use in the patient best induction and intubation agents with the neutral hemodynamic perturbation. In general, you cannot go wrong with ketamine for induction and rock for paralysis in critically ill patient, given that you won't have much in the way of hemodynamic consequences and you won't have to worry about transient rise in plasma potassium or oxygen utilization secondary to fasciculations from sustained coding. Thank you.
Thank you.
Voice is breaking, sir.
Can you hear me?
Yes, sir. Now you're audible, sir. Yes, sir.
So thank you very much for your this very lucid and excellent presentation. So there is one request in the chat box regarding the ultrasound. So
Yes,
can you again go through the ultrasound slides actually?
sure, sir.
We can share the video also, the recording also later on.
Yes, yes.
Okay, sir.
So just quick on a minute on the ultrasound actually again, Neeraj, if you can.
Sir, actually, these are this is not videos. These are the images which I've included in PPT. They're not videos, sir.
Can you just quickly go through in 1 minute about this
Okay,
ultrasound?
sure, sir. Sure, sir. I'll go through it.
Yeah.
Yes, friends. Yes, sir. Hello. So this is the image which showing the proper placement, tube placement. So this is a image, sir. There's only one interface with commercial appearance. So you can see one tube position properly with posterior echoing, sir. And if the tube is in esophagus, sir, there is double track sign, sir. You can see anteriorly and posteriorly, sir. So this is a test to assess the proper tube placement, sir, with use of UAG, sir.
So what is basically more important in a case of ultrasound? It is very handy. It is available in the bedside.
Yes, sir.
It is called the stethoscope for the intensivist actually. So it is used before intubation to check the position of the external anatomical structures, presence of any bulky thyroid, tracheal deviation, or any kind of mass or any abnormal anatomy. You can have a rough idea. Also after the intubation, you can have a good idea whether the tube is in the trachea or esophagus by the proper ultrasound learning.
Yes,
And
sir.
also check the position of the rise tube sometimes where it is your proper place or not.
Also,
So,
sir, we can assess the gastric ultrasound residue, sir, patient risk for aspiration because of UAG, sir.
correct. So these are the very very good advantage of having a very rapid assessment by the ultrasound team. And I sincerely say that everybody should be acquainted with this kind of well versed with the procedures because these are actually sometimes be life saving actually.
Yes, sir.
While doing a tracheostomy, percutaneous tracheostomy, also you should ideally have a pre-tracheostomy ultrasound assessment of the neck, just to know that your neck structures are in optimum condition.
Yes, sir.
So the another thing what I want to highlight regarding in the risk assessment, always ask for the good history actually. Sometimes the patients who are having a anticipated or unanticipated difficult intubation, if they have undergone any kind of procedures, anesthesia records, go through the anesthesia record, they may be aware that they are having a difficult intubation and it is told by somebody like some anesthesiologist or the surgeons. Sometimes they provide them with a difficult airway card also. So just think about such things and also go through their prior CT of the neck, the prior CT or X-ray of the neck or any kind of images which is available. These are the very important points to actually risk stratify yourself and to your team members that you prepare for any kind of difficult airway in such patients. So these are the certain take home points and always the training is very important. Always like your team, your juniors should be well trained, your nurses, your team leader, and always keep a good this thing like rapport with your surgeons. At the emergency, they always be ready to help you. So we remember a few cases where the surgeons have come in the mid of the night, particularly the first case what Dr. Ashwini had showed you regarding that particular your retropharyngeal mass where the
nightmare for us, sir. Nightmare, it was a nightmare.
And it was unanticipated, but fortunately it was discovered by one of our resident doing a just laryngoscopy. There is a big mass and he didn't try intubation because patient was absolutely stable, maintaining oxygen level. And this is just under the pre-oxygenation on mild sedation he discovered. And he just abandoned the procedure and called the surgeons. And the elective or you can say the emergency tracheostomy has been done in the night. So sometimes you may not find any kind of mass or any kind of anatomical difficulty from outside, but sometimes there may be a hidden challenges which is there inside your esophagus or in the retropharyngeal space. which cause these problems to be more aggravated once you give muscle relaxant and sedation. So do not attempt such patients in a heroic manner. Rather than to call for the help, call for the help is the single most biggest advantage for you also, to give you a peace of mind also, and to have a better team idea, and your surgeons can do a better job sometimes by doing a good emergency tracheostomy, and the patient life can be saved. So these are the few things from my side. And yeah, of course, Dr. Saurabh is here, Dr. Praveen is here. Anybody can have a comment on that and their personal experiences, which
Yeah.
can challenges.
I want to add one thing. Most of the time we focus on, assessing the airway, but sometimes, especially in hematology patients, when you are trying to intubate them, the moment you put laryngoscope there,
They
they will bleed like anything.
yeah.
And then it becomes such a difficult scenario because you are not prepared. If you are looking at the patient, today only we have intubated a patient. When we were intubated, we did not, outside it was not visible and platelet count was just okay, acute leukemia patient. The moment we did laryngoscopy, there were big clots in his mouth and he was bleeding very profusely. So the important point is just try to maintain your calm, call for help. Nobody should be ashamed of calling for help, which is very, very important. If you have two experienced person, it becomes really easy to tackle the problem. And a good assistant is always required for that. So bleeding also, it is oncology patients very, very difficult to handle. And sometimes it is tumor bleed. They start bleeding, then it becomes almost impossible. And as Dr. Gundar has rightly said that you have to have a surgery team standby, and we have a very, very good team with us. So they'll be easily available and they have saved us many a times.
Yeah.
Absolutely, absolutely. Dr. Saurabh,
Yeah.
your side?
Thank you, Dr. Ashwin, Dr. Neeraj, for such a
Yes.
lovely presentation.
Thank you, sir.
What I want to emphasize that the assessment and management of difficult airway in non-oncological patient is different from the oncological patient. The assessment is, as Dr. probably already said, in our assessment, the airway may look normal. For example, patient with CA tongue, here is a innocent looking ulcer, and as soon as you introduce your laryngoscope, the patient start bleeding.
Bleeding as
There will be obstruction in the trachea. That is not apparent from normal assessment. Of course, Dr. Gunther mentioned about CT scan and ultrasound. It can be done, but with the normal assessment, you won't be able to find out that there is a tumor.
And
Secondly,
normally we don't anticipate. So
you don't
what
anticipate. You
happens?
don't anticipate. And
APM
the
treatment
difficult
specifically.
difficult area algorithm that we follow in non-oncology patient are not applicable in this patient, because here we deal with a complete distorted anatomy. LMA may not be helpful because the tumor is beyond the reach by LMA. Even if you able to intubate the patient, still you won't be able to relieve the obstruction. Then you cannot do tracheostomy or tracheotomy because the anatomy is completely distorted. There is complete fibrosis. Here we are talking about pre-oxygenation, but here we talk about peri-procedural oxygenations with the help of HMNC. It will also give we can also buy time, and also it can give some positive pressure to stand the airway. Here we talk about in non-oncological patient, we talk about giving adequate sedation and muscle relaxation. But here we are very fearful, very scared of giving even sedation. The patient is trying to be to a narrow small passes, narrow air passes. And as soon as you forget about muscle relaxation, as soon as you give sedation, the patient will just collapse.
Yeah.
So here, even the fiber optic bronchoscopy won't be able to introduce because the passage is so small. Once you that fiber optic bronchoscopy itself block the airway. So here, as Dr. Praveen or Gunther said, that we need to keep our surgical friend nearby standby. And one more thing that we easily forget and we don't use so much, that is a rigid bronchoscopy, where nothing helps. A rigid bronchoscopy might be helpful to negotiate the obstruction, and you can maintain the airway. So, like difficult area in oncology patient, once if you don't see, you won't be able to imagine, you won't be able to anticipate. So you have we have to train ourselves working in this ICUs, in this dealing with this airway, so that we can prepare better.
And today we were lucky enough, so we could ventilate him with NIV. So that was the saving way. We did it very calmly. We somehow maintained our calm and we waited. He was being ventilated very nicely, so we could intubate him. But most of the times, if I don't know how many people have seen this, APML patients specifically, they will bleed so profusely. I have personally experienced, you'll put in a tube, they will bleed, the tube will be immediately obstructed, then you change the tube, it will be clots, then you another put, so it becomes really, really difficult. And in that patients, in those kind of patients, tracheostomy is also very dangerous because even touching laryngoscope, they are bleeding profusely. Giving an injection becomes a nightmare. So it is, APML is one of the, I think, most difficult conditions if they start bleeding.
They
Then
also have DIC propensity, that APL ML3
yeah,
type, M3
yeah.
type.
And
Yeah.
apart from these
Yeah.
radiation, fibrosis and all those
Fibrosis also,
known
yeah.
factors, they are always there. But APML and acute leukemia patients, they are a problem. If they start bleeding, they are a problem.
Yeah.
And yeah, somebody, Dr. Mohan Pathak, also has mentioned regarding the radiation to the neck. Very,
Yes,
very
yes.
important, actually.
Yeah.
If a patient has received radiation to the neck,
Nowadays, because of the advancement of radiotherapy, you don't see anything from outside.
Yeah.
But still, there is a fibrosis in the mouth. You can
Whole
able
of the anatomy is
able level the mouth.
distorted.
Yeah.
So once there was a patient, we were trying to intubate. We were trying for tracheostomy. So we called surgery team. They were preparing for tracheostomy. And it was a situation when we did laryngoscopy, whole thing was distorted. Nothing was visible inside. I think we lost that patient. Neither we could intubate her, neither we could do tracheostomy, and eventually we lost her. So that was one patient I always remember, and I think this is the airways. That is why airways is a nightmare for every day.
Especially
At
as
any
onco patients.
yeah, at any point of time, you can face that situation. We lost that patient.
absolutely, absolutely. And also, it is also very important that during extubation also,
Very
you
important.
very important. Like intubation, your extubation is also one of the very
Very
important steps.
important. And
It should be
underrated. People think that extubation hi to karna hai. That is one of the most, especially head and neck patients.
That is difficult.
It is very important to keep surgeons in loop that we are into extubating the patient. Everything should be kept ready.
And whenever you are finding any kind of oral pathology, never hesitate to ask the references, particularly the ENT references, or you suspect any kind of bleed or trauma or any injury to the oral airway during intubation also. So always evaluate before extubating the patient.
Very
That is an important take-home message for all the
And I think the one important message, onco or non-onco, every intubation should be considered as a difficult intubation until unless proved otherwise. So always prepared for the worst. If you are able to do it nicely, then it is good, but always prepared for the worst.
Yes, absolutely. So I don't see any further questions in the chat box, but there are a few comments. Like one comment like excellent presentation. Yes, thank you for all the. I think the credit goes to the organizers also for arranging such an excellent talk and the platform. And so these are the comments actually. So anybody like.
Sir, I want to add one thing. I had one young lady, old lady who had a MBR and presented with stridor. 1 year back, she had a MBR. And when we tried to intubate, tube was not passing. So we just kept subplotted tube for one. We call ENT surgeon. Patient was become hypoxic. The ENT surgeon was very confident. Anesthetic asked for 3D CT scan. But the ENT surgeon, without testing, he directly take a nick and tried to pass CT not passing. Then the Buji was not passing. Then tried to put a endotracheal tube 6-1 that was not passing. So that was a bloody situation, and then we lost that patient. So before doing crack, 3D CT must be done for if your patient has undergone endoscopy surgery. There is anticipated strictures of the tracheal. So this patient require emergency stenting. There is called a difficult airway specialist ENT in Mumbai safety. There are some fellowships are going on. They ask in this situation they do a emergency tracheal stenting. that can save the life. Or last option is more, but that is not possible for research limiting. And we should not hurry up for intubating such patient. If the patient is presenting with stridor, so whatever maybe we should not advance unless and until we have concrete plans, expertise bedside. Yes, sir.
Correct. And sometimes to save the patient in case of a very difficult airway, like particularly if there is a big intrathoracic mass or big mass in the neck, or sometimes where you find the bronchus is totally obstructed by the mass, and it is even if you intubate, you don't feel that the patient will get ventilation. Sometimes in 1 or 2 cases, I remember we have to go through this femoral bypass and do a, like you can say, extracorporeal maintenance of the oxygen, just like the ECMO. Or sometimes you can also put these patients on the ECMO only for this purpose. So only in my all this practice career, I have only one case, like particularly a big anterior mediastinal mass, which was like very difficult, and the whole bronchus was actually completely obstructed. That patient was put on femoral bypass, and the mass was excised before intubation. So these are very rare cases, of course, but one has to keep in the mind always. So in that case, you have to you keep your CVTA surgeon, your oncosurgeons, your ENT surgeons, everybody, your intensivist, and everybody in the loop actually. So the extent of that maintaining the airway can go to that extent actually sometimes.
And sir, one more complication that I have seen, that during percutaneous tracheostomy by that forceps method, if you do apply pressure, so that one time we had an injury to the internal jugular during percutaneous tracheostomy, and then patient bled. When patient was a ECMO patient already he was hypernized. So percutaneous tracheostomy, that by forceps and that by dilator method. So these both are very dangerous if the patient is on hyperinized. These are all flying techniques. So before then we require CVT surgeon, emergency anastomosis, patient required me thoracotomy. Fortunately, patient was in ECMO. Patient was on ECMO. That's why we could save this patient, because so percutaneous tracheostomy, especially lower incision, is also very troublesome. So before applying that forceps, method, we should be very calculative to how much we have to dilate, and if you dilate more, then we end up in injuring the patient if the patient is on heparin. Yes, sir.
Right, absolutely.
So I think there are no more questions. Thank you, Dr. Gundar. Thank you, Dr. Neeraj, Dr. Ashwini. It was very nice presentation.
Thank you, ma'am. Thank you for the opportunity.
Thank you very much to all of you.
Thank you, ma'am. Thanks for the
Thank you.
opportunity.
It's very nice.
Thank you.
Yeah.
So we'll close the webinar today.
Yes,
Yeah.
thank you.